Discuss the etiology, pathogenesis, clinical features, diagnosis and management of systemic lupus erythematosus, that is SLE. Systemic lupus erythematosus SLE is a chronic autoimmune disease which affects multiple organ systems. It is the most common multisystem connective tissue disease. Immunologic abnormalities, especially the production of a number of antinuclear antibodies, are another prominent feature of the disease. The prevalence is 50 to 150 per lakh population. 90% of affected patients are females, with peak onset in the second and third decades. It is more common in urban than rural areas. Etiology. Exact etiology is unknown, thought to be autoimmune. Genetic factors. There is a high concordance rate of SLE in monozygotic twins. It is more common in relatives of SLE patients. Risk of SLE is increased in those with HLA-B8, HLA-DR2 and HLA-DR3. Hormonal factors. Female sex and hormonal influence is a significant risk factor for SLE. Use of estrogen containing contraceptive agents is associated with increased risk of developing SLE. Elevated levels of prolactin are seen in patients with SLE. Immune abnormalities. SLE is primarily a disease with abnormalities in immune regulation. Affected patients are not tolerant to their self-antigens and consequently develop an autoimmune response. Phagocytosis and clearing of immune complexes and of apoptic cells are defective in SLE. Environmental factors. Some viruses, ultraviolet rays and silica dust may increase the risk of developing SLE. Pathogenesis. Genetic susceptibility, immune abnormalities and environmental factors leads to activation of helper T cells and B cells specific for self-antigens that leads to IgG autoantibody production that in turn leads to immune complex and autoantibody mediated tissue injury. Many components of intracellular and intracellular machinery act as autoantigens in SLE. In normal health, these antigens are hidden from the immune system and do not provoke an immune response. Interactions between susceptibility genes and environmental factors result in abnormal immune responses. This abnormal immune response results in the production of pathogenic autoantibodies and immune complexes that deposit in tissues, activate complement, cause inflammation, and over time lead to irreversible organ damage. Clinical features. SLE affects almost all the organ systems. Constitutional symptoms include fatigue, fever, weight loss, and mild lymphadenopathy. Raynaud's phenomenon, cold or emotion induced color changes of the digits of the hands and or feet is a frequent problem. Musculoskeletal features. Joint symptoms occur in over 90% of patients with SLE. The arthritis tends to be migratory and asymmetrical. Only a few joints are usually affected, especially those of hands. Joint deformities are usually rare. Avascular necrosis and tenosynovitis. Mucocutaneous features include the most common lesion is butterfly rash, erythema over the cheeks and nose which appears after sun exposure. It spares the nasolabial fold. The absence of pustules helps distinguish SLE from rosacea. Discoid rashes are characterized by hyperkeratosis and follicular plugging with a tendency to scar. Vasculitis, vasculitic skin lesions may include mottled erythema on the palms and fingers, periungual erythema, nail fold infarcts, urticaria, and palpable purpura. Other skin manifestations include livedo reticularis, photosensitivity, Raynaud's phenomenon, and alopecia, that is hair loss. Mucous membrane manifestations are painless oral and or nasal ulcers. Renal features include kidney is the most commonly involved visceral organ in SLE. Initially, it may be asymptomatic. Hence, regular urine analysis for proteinuria and serum creatinine measurements are important. Proliferative glomerulonephritis, lupus nephritis, characterized by hematuria, proteinuria, and urinary casts. Cardiovascular features include pericarditis leading to chest pain and pericardial effusion, myocarditis, and sterile Liebman-Sachs endocarditis. Liebman-Sachs endocarditis is characterized by non-infectious vegetations formed as a result of procoagulability in association with antiphospholipid antibodies, increased risk of venous thromboembolism due to the presence of antiphospholipid antibodies. Coronary vasculitis causing angina is rarely reported. Pulmonary features include pleuritis and pleural effusion, pneumonitis, interstitial lung disease, pulmonary hypertension, alveolar hemorrhage, shrinking or vanishing lung syndrome, pulmonary embolism. Neuropsychiatric features include fatigue, headache, poor concentration, visual hallucinations, chorea, that is also associated with antiphospholipid antibody syndrome, organic psychosis, transverse myelitis, lymphocytic meningitis, and seizures. Hematological features: Coombs positive hemolytic anemia, pancytopenia, anemia, leukopenia, and thrombocytopenia due to antibody mediated destruction of peripheral blood cells, splenomegaly, and lymphadenopathy. Gastrointestinal features include non-specific abdominal pain. SLE vasculitis can lead to pancreatitis, peritonitis, and colitis. Mesenteric vasculitis, hepatosplenomegaly. Ophthalmologic features include keratoconjunctivitis sicca due to secondary Sjogren's syndrome. Rare features are cotton wool exudates due to retinal vasculitis, episcleritis or scleritis, and uveitis. Diagnosis, investigations, complete blood count and differential count, anemia or pancytopenia is seen. Serum creatinine, urine analysis with microscopy, and 24-hour urine protein excretion to rule out renal involvement. ESR, CRP are elevated and complement levels C3 and C4 are decreased. Autoantibody testing. ANA, that is antinuclear antibodies, antiphospholipid antibodies, antibodies to double-stranded DNA, and anti-Smith antibodies may be positive. Antinuclear antibody ANA test is the best diagnostic test for SLE. ANA is positive in significant titer, usually 1:160 or higher, in virtually all patients with SLE. However, ANA is not specific for SLE and it can be positive in Sjogren's syndrome, scleroderma, and rheumatoid arthritis. Anti-double stranded DNA and anti-Smith antibodies are highly specific for SLE. Other antibodies that can be positive in SLE are antibodies to single stranded DNA and nucleoprotein, antibodies to ribonucleoprotein, and antibody to RO, SSA, and LA. Chest X-ray to look for pneumonitis, interstitial lung disease, etc. CT or MRI brain in people who present with seizures. Biopsy. Biopsy of an involved organ, example skin or kidney, is necessary in some cases. Diagnostic criteria. Revised American College of Rheumatology ACR criteria for SLE. A patient is classified as having SLE if the patient has biopsy proven lupus nephritis with ANA or anti double stranded DNA antibodies, or if the patient satisfies 4 of the following 11 diagnostic criteria, which include: first one, malar rash, discoid rash is second one, third one, photosensitive rash, fourth one, oral ulcers, fifth one, pleuritis or pericarditis, sixth, non-erosive arthritis involving 2 or more peripheral joints, seventh one, glomerulonephritis or proteinuria, eighth one, seizures or psychosis in the absence of offending drugs or non-metabolic derangements, ninth, hemolytic anemia or leukopenia or lymphopenia or thrombocytopenia, 10th, positive ANA test that is not caused by a medication, 11th, immunologic laboratory abnormalities such as positive antiphospholipid antibody or anti double stranded DNA or anti SM. Management. Educate the patient to avoid sun and UV light exposure and to use sunblock preparations. NSAIDs are enough for mild joint pain. Hydroxychloroquine 200 to 400 mg daily is indicated for all patients with SLE regardless of disease severity because it decreases disease flares and decreases mortality. It is especially useful in troublesome cutaneous and joint symptoms. Steroids. Steroids are required for mild to moderate disease activity, example rashes, synovitis, pleuropericarditis. High dose steroid, oral prednisolone 40 to 60 mg daily or IV methylprednisolone 500 mg to 1 gram in combination with pulse IV cyclophosphamide is required for life-threatening disease, that is renal, cerebral involvement, systemic vasculitis, diffuse alveolar hemorrhage. For maintenance therapy, oral prednisone less than or equals to 7.5 milligram once a day or its equivalent can be used along with hydroxychloroquine or azathioprine. Immunosuppressive drugs: azathioprine, methotrexate, cyclosporine, tacrolimus, mycophenolate, mofetil. These are useful either alone or in combination with steroids for severe but non-life threatening manifestations or as step down therapy after cyclophosphamide. Belimumab inhibits the production of antibodies by preventing the maturation of B cells into plasma cells. It is indicated for active autoantibody positive SLE which is not responding to standard therapy. Rituximab can be used in CNS lupus, including transverse myelitis. It is also helpful in refractory cases of hemolytic anemia and thrombocytopenia. Anticoagulants such as warfarin is required lifelong for patients with the antiphospholipid antibody syndrome with thrombotic events.